Good afternoon and evening to all of the attendees, of which there are many, I believe. Welcome to this evening's webinar. My name is Gretchen Burback. I'm a neurologist and epileptologist at the University Teaching Hospitals in Lusaka, Zambia, as well as at the University of Rochester in Rochester, New York. It is my great pleasure to be the host or the moderator tonight for our webinar, which will focus upon epilepsy and stroke. I think all the practicing neurologists out there will agree that this is a common problem we encounter and really can be the bane of our clinical existence. So the more we can learn, the better. We're very pleased and honored tonight to have with us from Ghana, Dr. Augustina Charwe-Feli. She's told me we can call her Dr. Charwe, which would be maybe easier for some of us. She is a practicing neurologist with a wide range of interests and skills, epilepsy and stroke definitely being among them. She is the immediate past president of the African Academy of Neurology and a very active member of the International League Against Epilepsy, as well as being on the African Commission. So it's my pleasure to introduce her. I know we're all looking forward to her talk. Please remember, we'd love to have lots of questions and answers, but it helps a lot if you put them in the chat. Raised hands might not get attended to, but if you look at the bottom of your Zoom screen on the Q&A, if you put your questions in there, we'll certainly have them addressed. And with that, Tina, take it away.
Good evening, good afternoon, my dear colleagues. It is my absolute honor and pleasure to have the opportunity to speak to you about this very important topic, epilepsy and stroke. We will cover the definitions of both stroke and epilepsy, the epidemiology of seizures with stroke. We'll cover as much as is realistically possible the pathophysiology of stroke. We will talk about using an electroencephalography in stroke management, the pharmacology of our anti-seizure medications, and the principles of management of post-stroke seizures. Now, before we start with the definition of stroke, it is important to note that in adults, stroke is one of the most common reasons for the development of epilepsy, and that's why it is such an important topic. So the updated definition of stroke for the 21st century sounds as follows. The central nervous system infarction is defined as brain, spinal cord, or retinal cell death attributable to ischemia based on the neuropathological, neuroimaging, and or clinical evidence of permanent injury. So in the past, we used to talk about stroke in a predominantly clinical fashion. So you have to have a clinical event, and you still need a clinical event, but it is not simply a clinical event. It is mandatory as a vascular cause of that neurological deficit, and you have tissue evidence on your imaging that there has been infarction. However, we all know that stroke is not only ischemic, we also have hemorrhagic stroke and subarachnoid hemorrhage, and this is also included in the definition of stroke. Next, the definition of epilepsy. So we all know, or should know, that in the 2005, the International League Against Epilepsy released a conceptual definition of seizures and epilepsy, followed by an operational or practical definition in 2014. We won't talk about the conceptual diagnosis. We will though emphasize the practical definition of epilepsy. So everyone has heard of these as well. So the first point, in order to be able to define something as epilepsy, is having had at least 2 unprovoked or reflex seizures occurring more than 24 hours apart. The next definition is 1 unprovoked or reflex seizure and a probability of seizures similar to the general recurrence risk, that is at least 60%, of 2 unprovoked seizures occurring over the next 10 years. Or finally, the diagnosis of an epilepsy syndrome on first encounter. Now, this is the one that applies to today's conversation, and that is one unprovoked seizure and a probability of further seizures similar to the general recurrence risk of at least 60% after 2 unprovoked seizures. And we know that it is that. We don't have to prove it. The science has shown that if you have an unprovoked seizure and imaging or EEG evidence of a focal pathology, then the recurrence risk is approximating to 60%, and therefore you have met the definition of epilepsy. And meeting the definition of epilepsy is important because it also mandates, once you have defined it as epilepsy, that you're going to manage it. All right, but I wish it was that simple. We also have to take into consideration what we call acute symptomatic epilepsy. And the ILAE definition of this is acute symptomatic seizures that are events occurring in close temporal relationship with an acute CNS insult, which essentially what a stroke is. So these CNS injuries can be metabolic, toxic, structural, stroke, infectious, or due to inflammation. The interval between the insult and the seizure may vary due to the underlying clinical condition. Other names for acute symptomatic seizures are reactive seizures, provoked seizures, and situation-related seizures. But the terminology we should be familiar with using is acute symptomatic seizures, a seizure that occurs in very short temporal association between or after a nervous system injury. So how do we define that time? Usually it's events occurring, so seizures that occur within 1 week of the topic at hand, a stroke, but we also use the term for traumatic brain injury, anoxic encephalopathy, intracranial surgery, the first identification of a subdural hematoma, the presence of an active CNS infection during the active phase of multiple sclerosis or other autoimmune disease. For the purposes of today's presentation, we will be talking about acute symptomatic seizures being those that happen within 1 week of a stroke. So, how often do we see seizures in stroke? I've mentioned this already. Stroke is actually the most common cause of seizures and epilepsy in older adults. In 6% of those who have had a stroke annually, they will develop seizures and epilepsy. Seizures shortly after a stroke, we have mentioned, can lead to increased metabolic stress and cell death, causing an increase in infarct size, mortality, and negative functional outcomes. Recurrent seizures may lead to injuries, worsening of cognitive status, and the ability to work and operate vehicles, and generally decrease quality of life. An older age, the presence of comorbidities, co-medications, so other medications, and the general vulnerability of stroke survivors must be taken into account when we are deciding when and how we are going to treat these post-stroke seizures. Now, there have been multiple studies on the risk estimates of epilepsy after stroke, and depending on how those studies are carried out, the results we get can vary. In the general population, prospective follow-ups of large cohorts or register-based studies provide the most representative estimates. From studies based in the UK, we see that an incidence of post-stroke epilepsy is about 6.4%, and also in a nationwide registry in Sweden in single-center studies from academic hospitals, which also found that younger patients with more severe stroke had a higher likelihood of developing post-stroke seizures, up to 15%. Is around 12%. The risk of post-stroke epilepsy is greatest within the first few years after a stroke, and in those who develop epilepsy, 85% would have experienced their first remote symptomatic seizure within the first 2 years of the stroke. So again, this is emphasizing that the first 2 years is critical. If you're going to have post-stroke seizures, within that period is when they're going to happen. I will come back to the question about, so what now if we know that the risk is that high? What do we do? So back to acute symptomatic seizures. The stroke has just happened. We're within 1 week. the epidemiology of this is a lot less defined and a lot less understood and a lot less documented. From the studies that we have, we see acute seizures in 1 to 4% of ischemic stroke, but up to 16% in intracranial hemorrhage. There are multiple mechanisms of the creation of an epileptogenic zone after a stroke. So first we have, let me get my pointer. Here, first we have this section where we are talking about early seizures, so early symptomatic, acute symptomatic seizures, and then late delayed symptomatic seizures. So here where we will be diagnosing epilepsy in somebody who has had a stroke. So this is an illustration showing that initially the stroke and its effects on the disruption of the blood-brain barrier, cellular hypoxia, electrolyte imbalance, hemorrhagic transformation, and ion channel dysfunction can lead to the early seizures. Subsequently, so after we're out of the acute phase, epileptogenesis can be acquired through secondary changes such as gliotic scarring, angiogenesis, siderosis, and other pathologies. This time interval between early and late seizures is typically segregated at 7 days after a stroke. So within 7 days of a stroke, we're talking about acute symptomatic seizures, and it is not entirely arbitrary, but it is just a defining timeline. And then late seizures are less clearly defined, but occur mostly after the 7 days after a stroke, within the first couple of years after a stroke. Now, similar to the distinction between transient ischemic attack and infarction and the movement away from a time-based definition to a tissue-based definition, similarly, the 7 days between an early or a late seizure has also shifted from a time-based to a tissue-based approach. So although a transient ischemic attack was traditionally diagnosed on the duration of symptoms within 24 hours, we know this is the old definition. The new definition is symptoms resolving spontaneously within 1 hour and this is important, tissue-based diagnosis, no evidence of infarction on appropriate imaging, which is usually an MRI. Similarly, it is increasingly recognized the distinction between early and late seizures should be tissue-based, and identify epileptogenesis is crucial for selecting the most appropriate treatment base for post-stroke epilepsy. So we have been able to identify risk factors that make post-stroke epilepsy more likely. And that's the so the person with the stroke having had acute symptomatic seizures, cortical involvement of the lesion, the stroke severity and size, and the etiology of the stroke, a younger age, and the stroke type. So hemorrhagic stroke is more likely to give you post-stroke seizures than an ischemic stroke. But again, please remember it also depends on the location and the cortical involvement of the stroke, irrespective hemorrhagic or ischemic. So a meta-analysis found that acute symptomatic seizures, cortical involvement, and hemorrhage are more likely to increase the likelihood. So basically that's a synopsis of what we have just said, the likelihood of developing epilepsy after stroke. Then back to this definition. So it depends on the tissue, which part of the tissue is involved in the process, and where the epileptogenesis is able to occur. Again, we know that the cortex is very important in the development of the epileptogenic zones, and therefore, hence the things that we have spoken about. So this is just a reminder going back to the previous slide. Then furthermore, we have comorbidities that make post-stroke seizures also more likely, but these are less consistent than the ones we have spoken about before. So some results report an increased risk of vascular epilepsy in those with diabetes, dyslipidemia, hypertension, peripheral infections, depression, and already pre-existing dementia to the stroke. Are there any neuroimaging characteristics that we can use to predict the formation of epileptogenic zones. Unfortunately, so far, no specific technique has proven particularly useful in visualizing epileptogenesis beyond what we've already mentioned, the lesion being close to or within the cortex. Some clues on the risk of post-stroke epilepsy can be obtained from MRI or CT scans, and these are the involvement of the cortex. As we've mentioned, they are highly associated with later seizures. Subcortical stroke does not appear to increase the risk of post-stroke epilepsy. Seizures are most common if the infarct or bleeding occurs within the anterior circulation, so that's the anterior cerebral artery and the middle cerebral artery, and more specifically, a higher likelihood when it involves the medial cerebral artery territory. Seizures are uncommon if the stroke affects only the infratentorial structures. So if you have a pontine lesion or a cerebellar lesion, you are very unlikely to have seizures. And if you do, it is probably not because of the stroke itself, but other factors. Larger lesions are more likely to cause seizures, and we know that a lesion size greater than 70 milliliters increases the odds seizure by 4-fold. So a few scores have been created to help with these predictions. One such score is the SELECT score for risk assessment, and the basis of the score is determining the severity of the stroke. So an NIHSS score of less than 3 gives you 0 points, between 4 and 10 that's 1 point, greater than 11, that's 2 points. And again, remember, we've already mentioned this, but this is putting it in a numerical form. The greater, the larger the stroke, the more likely you are to have post-stroke seizures. Again, the NIHSS score, the disability is also dependent on the size of the stroke. If you have large artery atherosclerosis, if there's none, 0 points. If there is, 1 point. Do you have early symptomatic seizures? No, 0 points. And if you do, quite a significant risk factor, 3 points for early seizures. If there's cortical involvement, 2 points. Depending on the territory of the stroke, is it within the middle cerebral artery? If yes, 1 point. If it's not within the territory of the middle cerebral artery, you get no points. So as we can see, based on the score, so this is SELECT score from 0 to 9 going upwards, the higher the stroke, the greater the likelihood at 1 year and at 5 years to have developed post-stroke epilepsy. This again is a pictorial demonstration of this. The higher the stroke, the greater the percentage and the risk of remote symptomatic seizures after 1 year and after 5 years. There's another score, the CAVE score, and this has been developed to gauge seizure risk after intercerebral hemorrhage. So the one we spoke about before, the SELECT score, was for ischemia. The CAVE score was developed for intercerebral hemorrhage, and it includes the factors of cortical location, that's the C in the CAVE, younger age, the A for the A, the volume, large hematoma volume, and acute symptomatic seizure. So again, like in ischemic stroke, having an acute symptomatic seizure increases the risk of developing post-stroke epilepsy. All right, the highest score, 4, indicates a 46% risk of later seizures. Now, please note that this is not equal to, when we mention the definition of epilepsy, a probability of 60% likelihood of developing of seizures over 10 years. So please do not use this score. It is predicting that the probability is high, 46%, but it doesn't mandate the development of epileptic seizures. Now, it's important to take note of this because your choice of management depends on how you interpret these results and what you do about them. So here we have the calculation of the CAFE score. Is there cortical involvement? Yes, 1 point. Is the patient younger than 65? 1 point. Is the hemorrhage volume more than 10 milliliters? Also 1 point. Was the acute symptomatic seizure? 1 point. So that's where you get the 4 from. So if we look at 0 points, the derivation is 0.6% seizure risk. And when we get to 4, it is 46.2%. So these scores are helpful in stratifying the stroke survivors into low or high risk categories for the development of post-stroke epilepsy and a guide to targeted follow-up, not management. No treatment so far, please note, no treatment so far has proven beneficial for primary prevention of post-stroke epilepsy. In other words, we do not, like in other situations, use anti-seizure medications as prophylaxis of future seizures if none have yet occurred. All right, so although these scores are not an instrument to guide primary preventative treatment, they can be used as recruitment tools for prospective studies on anti-epileptogenic medications. So please note, this is not a guide to decide whether or not you put your patient on medications, but can be used for studies. There are other markers that we can look for to help with the prognosis of the development of post-stroke seizures. And the chemical biomarkers are based on how the neuronal damage happens. So stroke-induced acute neuronal damage, hypoxia, metabolic dysfunction, global hypoperfusion, glutamate excitotoxicity, ion channel dysfunction, and disruption of the blood-brain barrier triggers a neuroinflammatory cascade. Consequently, multiple inflammatory mediators are released to repair the brain damage, and these are damage-associated molecular patterns, cytokines, chemokines, complements, prostaglandins, and growth factors. When neuroinflammation persists over time, it can lead to neuronal and astroglial dysfunction and consequently altered synaptic transmission, hyperexcitability, neuronal loss, gliosis, and aberrant neurogenesis. So all these mechanisms may be involved in the process of epileptogenesis. So do we measure them? Are they helpful? Not so much. Some of the inflammatory molecules released in the brain have been evaluated as biomarkers in several stroke complications, such as hemorrhagic transformation and pneumonia. However, in predicting epilepsy after stroke, these biomarkers have proven not very helpful, at least to date. So there are more biomarkers and more of the neuronal damage, etc. So for acute symptomatic seizures, we know that they are associated with higher neuronal cell adhesion molecules, lower tumor necrosis factor receptor 1 in the blood in the first 6 hours. But again, in terms of helpfulness in the management of our patients, these are very limited. This is a pictorial demonstration of all the different markers that have been looked at for acute symptomatic seizures. And as you can see, there is minimal difference. So some increase in the NCAM and FASL, and not really any difference in predicting remote symptomatic seizures. Now, what about doing an EEG after somebody has had a stroke? The electroencephalogram has a high temporal resolution, and it is important for the evaluation of brain function in real time, and to date is the gold standard for identifying different epileptogenesis and ictogenesis biomarkers. A systemic review and meta-analysis has found that the ictal and interictal epileptiform activity on EEG after stroke is found in 7% and 8% of patients respectively. These values may even be higher if long-term monitoring is done. And an example is identification of a spike wave pattern in a focal seizure
Sorry, we're having a technical issue. Just bear with me one moment.
Perhaps while we're dealing with that, Dr. Charway could answer a question from Dr. Khan asking if large hemorrhagic strokes, in those circumstances, should patients be started on prophylactic anti-seizure medications?
Thank you very much for that question. That the whole point of the section that we were talking about right now is that unless the individual has had a seizure, using medications as prophylaxis is not recommended in any guidelines. If a seizure has indeed occurred, we manage it as the acute symptomatic seizure as we would a seizure in any other situation, provoked or otherwise. So benzodiazepines would be your first point of call. But just simply having a large hemorrhagic stroke does not require the starting of anti-seizure medication if the patient has not had any.
Thank you.
Is done. And an example is identification of the spike wave pattern in a focal seizure of focal epileptogenic changes in someone with a focal lesion on their brain imaging. Among the patients with acute stroke receiving EEG monitoring, and I do recognize that most of our services will not have EEGs readily available, let alone for monitoring, but we are all striving to practice at the highest standards possible. Anyway, amongst patients with acute stroke receiving EEG monitoring, epileptic activity can be detected in up to 17% of cases. In ischemic stroke, 11% had seizures, 9 had exclusively non-convulsive seizures, and 7% fulfilled criteria for non-convulsive status epilepticus. For this reason, even in the absence of an EEG, if your patient is obtunded and you can't simply explain the loss of consciousness or the reduced level of consciousness by merely the size or location of the stroke, please do consider non-convulsive status epilepticus or just a non-convulsive seizure as part of what may be happening with your patient. We also know that non-convulsive status epilepticus is associated with poorer outcomes and increased mortality. A prospective study had found that non-convulsive status epilepticus occurs in up to 4% of patients with acute ischemic stroke. So clinicians often did not suspect ongoing epileptic activity in 40% of these cases with non-convulsive status epilepticus on EEG. Therefore, this is recommendations for having prolonged EEG monitoring to help detect status epilepticus in patients without typical signs of ongoing seizures. Now, what is the significance of seizure control for prognosis? So it's one thing we have said our patients are likely to have seizures. We've explained why the seizures happen, but what should we do about them? So a nationwide cohort study in Sweden revealed that post-stroke epilepsy had a significantly increased risk of all-cause mortality, which remained elevated after adjusting for various factors, including age, comorbidities, and stroke severity. A cohort study in Taiwan reported a mortality rate of approximately twice as high for patients with post-stroke epilepsy as that for patients with stroke without epilepsy, and 4 more times higher than that of the healthy population. And post-stroke epilepsy is an independent predictor of mortality amongst patients with intracranial hemorrhage in a population-based cohort study in Finland. So we have determined that our patients meet the definition for epilepsy or even acute symptomatic seizures. What and how do we use? Just a brief, again, reminder, anti-seizure medication is a medication which decreases the frequency or severity of seizures in people who are having seizures, epilepsy. It treats the symptom of the seizures and not the underlying epileptic condition. It does not prevent the development of epilepsy in individuals who have acquired a risk for seizures after head trauma, stroke, or tumor. So please remember again, this is just reiterating the fact that we do not use anti-seizure medication as prophylaxis for seizures in someone who has not had any. The goal of therapy is to maximize quality of life by eliminating seizures or diminish the seizure frequency or severity, whilst also minimizing adverse medication effects. So the attainment of seizure freedom should not be at the expense of side effects. So we have decided our patient needs medication. Which medication first? Does one size fit all? No. As in epilepsy in general, epilepsy in stroke requires an individual approach. It's important, in order to be able to perform this individual approach correctly, that we take into consideration the pharmacokinetic principles of the medications. Things like absorption, how does the medication enter the blood, essentially complete for all anti-seizure medications, with the exception of gabapentin that has saturable amino acid transport systems. Timing varies widely by medication, formulation, and patient characteristics. It is very important that we know how our medications are supposed to be prescribed. Is a once daily dosing appropriate? Is it twice daily? Is it 3 times daily? What else is happening with your patient that will mandate a change of the medication and how you give the medication? Or are there certain things happening with your patient that make one medication less desirable than another? Our medications are usually, the absorption of it is usually slowed by food in the stomach, with the exception of carbamazepine, and usually takes several hours before we get to peak plasma dose. What about the elimination? The elimination is the removal of active medication from the blood by metabolism and excretion. The metabolism and biotransformation is generally hepatic, usually rate-limiting step. Excretion is mostly renal for most of the medications. There are active and inactive metabolites, and it's important that we know, especially when we have patients with comorbidities of renal disease, hepatic disease, kidney and liver disease. There are also changes in metabolism over time, such as caused by autoinduction with carbamazepine or with polytherapy and enzyme induction and inhibition. There can be differences in the metabolism by age and, again, as mentioned previously, systemic disease. So we will not dwell too much on this. It's just a reminder that our different medications have different mechanisms of action. Some are blockers of sodium channels, GABA enhancers, glutamate modulators, calcium channel blockers, etc. We will not dwell on this, but it is important when you're choosing your medication based on other medications that the patient is on, that we choose suitable for drug-drug interaction choices. All right, and let's again not forget, this is just a reminder that we have to bear in mind the therapeutic index of the medications, which is the effective dose of the medication, 50% over the therapeutic dose of the medication, also 50%. There is limited data on many of our medications. It involves very broad generalization, and each individual can have a difference, and therefore when we're talking about therapeutic index, we have to remember that these are very individual things. All right, and then particularly important is to note which of the anti-seizure medications are enzyme inducers, especially of cytochrome P450. There are broad spectrum inducers such as phenobarbital, primidone, phenytoin, carbamazepine, selective cytochrome P3A inducers, oxcarbazepine, topiramate, felbamate. In general, the Cytochrome P450 is the one that is most involved in medication metabolism, and the nomenclature is based on the homology of amino acid sequences. The enzymes have broad substrate specificity, and individual medications may be substrates for several enzymes. There are other metabolizing enzymes to bear in mind. We won't dwell on this again, but again, when we're choosing our medications, we need to take these into consideration. Just a general reminder, anti-epileptic medications that induce the hepatic enzymes, carbamazepine, oxcarbazepine, phenobarbital, phenytoin, primidone, and topiramate, and non-inducing anti-epileptic medication, acetazolamide, benzodiazepines, ethosuximide, gabapentin, lamotrigine, levetiracetam, tiagabine, valproate, vigabatrin. All right, so we have a patient who has just had a stroke and also has a seizure. How will we manage the acute symptomatic seizures? We've mentioned already the temporal cutoff for what we call acute is 7 days, less than 7 days, versus remote, more than 7 days of the symptomatic seizure after the stroke onset. Early seizures are assumed to be caused by potentially transient processes in the acute phase after stroke, including hypoxia, cerebral perfusion shift, neuronal metabolic dysfunction, excitotoxicity, as well as disruption of the blood-brain barrier. We've mentioned this already. And although they occur infrequently, they have been associated with elevated mortality and a risk factor for further development of epilepsy. Now, the factors that we have mentioned that are likely to trigger acute seizures change the concept of an unprovoked seizure. So there is clearly something that is provoking the seizure. Those who have had acute symptomatic seizures after stroke have a 10-year recurrence likelihood of about 33%. Now, this is important. Remember when we were talking about the definition for epilepsy, in order for this to be a defining characteristic, to decide that my patient has epilepsy and I have to put them on long-term anti-seizure medications, the increased risk is only 33%. 33% is a lot, but it's still only 33% and doesn't meet the definition of more than 60% likelihood of recurrence. So acute symptomatic seizures alone are insufficient to diagnose epilepsy and therefore do not warrant management with long-term anti-seizure medications. So overall, the management of these seizures is still very much debated, and given the low recurrence risk of acute symptomatic seizures, the initiation of anti-seizure medication is usually not recommended. I will say that many practitioners would not follow the general guideline recommendations and do administer anti-seizure medications for acute symptomatic seizures. The challenge with that is that we have very few adequately powered control trials for the prevention or even treatment of acute symptomatic seizures. So what do we do? Benzodiazepines for seizures that do not stop spontaneously. Status epilepticus, if the patient is in status epilepticus, is treated like any other status epilepticus. And here you can use loading doses of phenytoin with precautions, loading doses of levetiracetam if you have that available in your center, or phenobarbital. Ideally, especially for non-convulsive status epilepticus, if you have EEG evidence of epileptiform activity in patients with reduced consciousness, please do manage appropriately. Now, we should all by now be familiar with this pictogram, and I have included it because of the importance of, when we are managing epilepsy, to take into consideration the comorbidities, which is why we spend so much time talking about the enzyme inducers and mechanisms of action. So, in general, there's no hard and fast rule, there's no blanket bans on any medication, but because our patients with stroke are more likely on other medications, we should, as much as is realistically possible, avoid the enzyme inducers such as carbamazepine and phenytoin because they have a great deal of drug-drug interactions. They can also be arrhythmogenic, and many of our patients with stroke already have structural heart disease and are prone to arrhythmias anyway. Phenobarbital, unless we're using it for status epilepticus, should also be avoided as it is sedating. It confuses the picture. If our patient has a reduced level of consciousness, we cannot tell the difference between it is because they are sedated because of our medications or because something else is happening to them. It increases their risk of falls and potentiates cognitive impairment. And we know, again, also aside from epilepsy, stroke is a risk factor for the development of cognitive impairment. So there is no need to add to that. Now we are going to use this algorithm for the choice of a first anti-seizure medication that we would use for anyone with epilepsy, but we're going to pay particular attention to these parts. So let's say we have defined the patient as having epilepsy and therefore mandating the use of long-term anti-seizure medication, and therefore we have decided to treat. If we have focal onset seizures, the question is this a frail elderly patient? If yes, our choices are valproate, levetiracetam, lamotrigine. If there are behavioral abnormalities, we would avoid levetiracetam as they can potentiate those. If you are not elderly, but you are on other medications, warfarin, antihypertensives, etc., again, back to this, unless you are a woman, in which case, end of childbearing age, whilst not the most ideal, carbamazepine is an option, and lamotrigine for patients who can afford it, or for those of us who have it even available. So we've come to the end, more or less. What are the take-home points of the presentation? So first and foremost, again, to reiterate, stroke in adults is the most common risk factor for the development of epilepsy in adults. How we approach the management, how we combine our medications is important because our patients already have a disability. Not managing their seizures worsens outcomes. And the treatment of post-stroke epilepsy needs to be adapted to the individual, considering the changes in the pharmacodynamics due to older age, comorbidities, and co-medications. Also, because older adults are more prone to adverse effects from anti-seizure medication, we need to be careful when we're choosing our medications, again, so as not to worsen outcomes with the medications alone. I thank you all for your attention. These are my resources. These are not all my resources. There are a lot more. I do recommend we look at this article, Seizures and Epilepsy After Stroke, Epidemiology and Biomarkers. Very helpful article. But realistically, in our environment, we need to look at the kinds of things we have available in our setting and make protocols that we can still individualize to each patient that are applicable for our settings. Thank you very much for your attention.
Thank you for that wonderful and very informative talk. We have a number of questions, and we can start with Deanna Middleton, who began by thanking you for making that important distinction about instruments for research versus clinical decision-making. She asks whether it's easy to get EEG wearables to help obtain post-stroke data for clinical prediction.
Thank you very much. I will answer the question two ways. The first way is for the setting that most of us listening to this presentation are in, and that's in the African context. The answer to that would be no, because these things are not readily available for most of our patients. That said, in other settings, in Europe, in the Americas, it is possible. Still not widely available, but it's definitely possible and usable to adapt and get more appropriate information as to the frequency of seizures, because again, not all seizures are the tonic-clonic convulsive seizures that are easy to recognize. There can be smaller non-motor seizures that can be missed. So those can be used. Again, it's still not widely available in general practice. So food for thought and an avenue where we can explore in terms of research and making diagnosis of these problems easier anywhere. But for those of us here in Africa, it's a dream that we are not close to yet.
Thank you. And a couple of questions about how long does one give anti-seizure medications after seizures have occurred post-stroke?
So that's a good question. It is essentially not different from how you would manage any other kind of epilepsy. So the epilepsy medications are used for as long as the risk of recurrence is maintained. That means if you have a neurological deficit and you have imaging evidence of tissue damage involving the cortex, a withdrawal of anti-seizure medication, even if you have achieved seizure freedom, can be dangerous because the underlying reason for why you needed the anti-seizure medications in the first place has not gone anywhere. The same way you would approach when to withdraw anti-seizure medications in anybody, there are certain fairly hard, fast rules. So number one, a normal neurological exam, so no neurological deficit, a normal intellectual status, or in an older person, no cognitive impairment, and of course, that you have already achieved seizure freedom. So the challenge occurs in terms of what to do with the medications, not so much when to stop, but if we are having side effects, intolerance, or intractable seizures, how to approach choosing the medication, how high to go, when to introduce another medication, how many medications is sensible to introduce. That is more a challenge than the conversation about when and how long to give medications for. So essentially, the medications are given for as long as is necessary.
We have a couple of questions about concerns about how one identifies seizures in the post-stroke period. Given the commonality of non-convulsive seizures and the difficulty of diagnosing them, do you recommend routine EEG in the peristroke period?
So that was what was indicated in the slide talking about the use of EEG after stroke. The yield is not 100%, and even those non-convulsive, the percentages are not high. So where possible, and especially in someone whose level of consciousness is impaired, where you can't tell whether or not they're having a non-convulsive seizure just by looking at them, that is when it is really useful. But just routinely for just anyone, I don't think serves a purpose and will be misuse of a resource. The utility, again, for our clinical settings where the majority of us will not have access to even a standard EEG, let alone EEG monitoring, the way to be able to identify whether a problem, a movement, and it's usually a motor one, is a seizure or not a seizure, is the involvement of the paretic limb. If the paretic limbs are moving, then it is probably a seizure, especially if it's paroxysmal as well. So sometimes I find that patients are inappropriately identified as having seizures when the only limb they can move is the one that is moving and shaking. And then whoever is observing it says, oh, the patient is having a seizure, let's put them on anti-seizure medication. So in order for us not to get confused, the epileptogenic focus is usually the stroke lesion. And therefore, whatever effect it's giving will happen on the side of the body that is affected by the stroke, so the paretic limbs. And that's one of the ways where you can identify or avoid misidentifying, because I found that we have sometimes the opposite problem, under recognition of seizures, but sometimes we have misrecognition of things that are not seizures as seizures. So I like to say to my residents and house officers, not everything that shakes is a seizure, but also not every seizure shakes. So it really is important to be able to correctly identify. And of course, in those situations when you're not sure, an EEG will go a long way in helping identify the problem. Yeah. But to say that it has to be a routine part of management for everybody with a stroke, I think that would be misuse of resources.
And there are a number of questions around the issue of your threshold for commencing an anti-seizure medication if somebody has had a seizure. So maybe one acute post-stroke seizure and that wouldn't be sufficient, but sort of at what point would you say, right, we need to start medications?
Good question. So the general rule, again, has to be applied to where you are and the individual patient, is if they have an acute symptomatic seizure, so within the first 7 days of the stroke, that individual event is the thing that is managed without long-term use of medication. If they happen to have, outside of that acute period, a seizure or another seizure, that is enough to warrant the initiation of long-term anti-seizure medication. The challenge with the acute symptomatic seizures is that many clinicians in all environments, not just ours, will sometimes, even though it is not in the guidelines, still initiate anti-seizure medications at that point. Like I said in the presentation, there are no studies that prove that it is of any particular benefit. And if we're not sure what the benefit is, aside from risking side effects, you're not really helping your patient. So I would desist from it. But again, it all depends on your clinical setting, the individual patient. If you have managed to get enough scores on all the different scales and you feel that the risk is high enough and your EEG is pointing towards it, you would not be held accountable if you do start anti-seizure medications, but great thought needs to be put into it before anti-seizure medications are started. If you are long after the acute period, so let's say 6 months later, 2 years later, and you have a seizure, and the individual has a neurological deficit, and their scan obviously also still has a lesion, then no question about it, after that single seizure, you start anti-seizure medications.
Thank you. And then there's a number of questions around the EEG findings. So if you suspect someone has had a seizure and you get an EEG and you see discharges, would that be enough for you to say, right, this is an active focus and this is someone that needs to be treated?
Depends again on when. In the acute period, not necessarily. In the remote period after the stroke, the EEG is not even relevant at that point. If they have had a documented seizure, that's enough evidence, and they have neurological deficit, and you know that their imaging has a lesion on it, then that's enough.
And then I have a question. So I was interested in the risk factors that you outlined, and I'm struck, in the first for people who are presenting with advanced HIV, the first 6 months after therapies are initiated, their stroke risks are quite high. And I have seen a few of those individuals then presenting with post-stroke epilepsy as well. So now you have a very complicated situation. Can you speak a little bit about anti-seizure medications in that population who now they have HIV, they're on antiretroviral therapies, they've had a stroke, and now you're also managing epilepsy?
Yes, so a very difficult group to manage because of the interactions of the medications. Even without stroke, the probability of developing seizures because of neuroinfections is quite high. Here, the choice of the medication again is very difficult, especially in our environment with limited availability of things. The reflex that I have noticed that happens is to use carbamazepine. Unfortunately, carbamazepine, being the powerful inducer that it is, it will make the antiretrovirals not as effective. And then the other way around as well, the antiretrovirals will make the carbamazepine not as effective, so you need higher doses. And so it becomes a vicious cycle. So in that category of patients, irrespective of the reason why they need anti-seizure medications, carbamazepine should not be a first choice. So valproate is better because it's not an enzyme inducer. If you have access or the patient can afford, medications such as levetiracetam and lamotrigine are far better than carbamazepine. That said, where you don't have anything else, carbamazepine will have to do. It's definitely still better than having seizures, but it would not be the best.
We have a question, could post-stroke recurrent headaches be suspicious for epilepsy, and can EEG detect abnormalities?
Oh, that's an interesting question. I don't know if I have a simple answer for it because I am not sure that we can interpret headache after stroke as equal to post-stroke headache and therefore being in relation to epilepsy. I would have to take a very thorough history and see what's happening to the individual before they develop the headache. Because we do know that after an epileptic seizure, most people will have some kind of headache. So perhaps I would be looking for phenomena that precede the headache or together with the headache before I consider epilepsy as a possibility and as an explanation for the the headache. The danger of using an EEG to decide what it is that you will, if they've had a stroke, your EEG might very well have focal changes, but that does not automatically mean that your patient is having seizures. So again, it's all about determining phenomenology or perhaps trying to get an EEG recording. So this is long-term monitoring, an EEG recording during the time they have their headache. And if you have very specific epileptiform changes, then maybe that would be the answer. But that would be really difficult to determine. I would look deeper into the characteristics of the headache and then what phenomena are happening around the headache before I make a determination of whether it has anything to do with epilepsy.
Yeah. And then a question that, if a seizure occurred that was prolonged, say 5 minutes or more, at the time the patient presented to the hospital, but then they've regained consciousness, is there still a need to treat that as status epilepticus?
I think the answer is in the question. If you have regained consciousness and you're no longer having any motor phenomena, then you are no longer in the seizure, and so you cannot be in status. The reason why it's important to stick to definitions is that the definitions then lead you into what you have to do. So like we defined what epilepsy was, it leads you to, once you have said that something is epilepsy, you need to treat. The same goes for status epilepticus. You have to meet the definition for status epilepticus in order for you to treat as status epilepticus. So, for example, it's recurring seizures without regaining consciousness in between, or a seizure that is prolonged and you're not regaining consciousness. So we don't need to wait for the 30 minutes of the WHO definition because it's late then. So 5 minutes is usually the gauge. But even if it took, I don't know, 30 minutes for them to get to you, but by the time they got to you, the phenomenon is no longer present, the point of application of our medications is no longer there. So it doesn't justify, again, the risk because all our medications have side effects. It doesn't justify the risk when the benefit is unknown.
Thank you. I think that's our last question, and we are at the hour. So I'd like to thank our speaker, for really interesting and vibrant and
pleasure.
well-received talk, and our attendees. And also to say that the Global Health and Epilepsy Project Database provides a registry of existing epilepsy projects throughout Africa, the Eastern Mediterranean, as well as in other regions. It identifies information such as project location, institutional partners, project scope, funding sources, and volunteer needs. The database is quick and easy to complete. By submitting information on your project, you inform understanding of efforts that are occurring throughout the world to narrow the epilepsy treatment gap. The database will provide you an opportunity to learn from others and to explore collaborative opportunities that might strengthen your own work as well as that of the sector. Furthermore, the database will allow people from different areas, such as government, academia, nonprofit, and philanthropy, to learn about existing efforts while offering a means to engage. On the next slide, please scan the QR code to receive your certificate. Also, there is a link in the chat box now to the certificate. Thank you everyone for attending, and have a good rest of your day or evening.
Thank you, everyone, and Eid Mubarak to whoever celebrates.